Okay, now we're going to transition to another sensory system. This is a sensory system that's very old. Obviously, it's something that organisms at very basic level have. And this is our somatosensory system, our cutaneous system. You think of it as the system called touch. Touch is a system that involves neurons embedded in your skin mostly, but that's a little misleading. It's in at least the idea that touch is something that's mediated only by your skin. There's also somatosensory receptors in the joints of your skeletal system. There are cutaneous sensory systems in your muscles. And all these systems work to help you form an idea of where your body is positioned, how it's positioned, what might be touching it, and how you may be touching other objects. But it's important to understand that a big part of the system deals with how your body is positioned in space. Now remember, you have a spatial model in your right hemisphere of the world and your body's position in it. Well, the somatosensory system contributes a lot to that position sense. And you take this completely, utterly for granted. If you watch one of the movies on the website, you'll see somebody who's lost their proprioception, and that's the sensory system that's within your body. And that person can't even walk. In order to even come close to ambulating, one patient was able to do it by incredible amount of practice, looking at where his limbs were positioned all the time, and was able then to walk. You don't have any sense at all of how much you use this system and how important it is for you to position your body in space. Okay, well, the system is designed like you see this homunculus here. As you might imagine, you have much more sensory abilities in the skin of your face and your hands than you do in other parts of your body. And they're even laid out in special places on your brain. If you go to the somatosensory strip of the parietal cortex, the somatosensory strip is the first gyrus of the parietal cortex, and you see it up there in green. Well, all the sensory systems come in to this tissue first. So they go to the thalamus, and they go to this tissue here. So when you touch your lips, the sensory neurons in your lips convey information to the area that's indicated there by lips. If you touch your nose, it's the nose area. If you touch your hand, your fingers, and so on, you can see where the different parts come in. Now, neurologists, of course, use this to diagnose illness. I mean, if you lost sensation in a certain part of your body, then they can tell what part of your brain has been damaged. I remember a patient that I saw a long time ago who had gotten a gunshot in the head. He was bending over, and a policeman shot him in the head. The bullet bounced off his skull and produced a very small, well-circumscribed, depressed skull fracture right over the sensory strip that was mediating his lower left limb. So his right hemisphere was struck, right at the area you see there where the foot and the arm is. That's where the depressed skull fracture was, and he lost sensation in that area. And so that was an obvious. You don't need to, since the person has a depressed skull fracture there. You don't need this to use to make a diagnosis, but it illustrated how circumscribed the innervation is of neurons in the areas that correspond to different parts of the brain. Now notice that your tongue, is down below your face, that your hand is pretty far from your arm, and your hand and your face actually seem to share the same general area. Well, this becomes important later when I show you some pictures of, or a movie of a neurologist named Ramachandran who studied phantom limb phenomena. And we'll get to that in a later part of the course. But just remember that the face and hand are near each other. Here's the basic layout of how the receptors are embedded in your skin. And I'm going to go into detail on each one of these receptors in a second. But right now we just want to see how how they're basically positioned in your skin. So here's a small section of skin. And you can see you have hair follicles there. And you notice that there are neurons that innervate the hair follicles. So when that hair follicle is moved, when you touch it, that free nerve ending responds, and you stimulate it, and you therefore know a part of your skin that you've touched. Notice that there's a layering to your skin. There's an epidermis, which I believe is the area of your skin that doesn't have any living tissue in it. It's all dead skin cells. It's constantly sort of replaced. Then you have the dermis, which consists of layers of fat and skin tissue that is alive. And notice that embedded in the dermis is where the receptors are. There are no receptors in the epidermis. Even though the epidermis, when you touch it, it's going to respond down to the dermal layer. This is another good example where neurons, they have to exist in a living medium. They can't be out there in the air or in areas where there's not a fluid medium to support them. Notice that there are free nerve endings. There are Meissner's corpuscles. See those blue corpuscles sitting up there close to the epidermis. Then there are Pacinian corpuscles, which are down lower. There are Ruffini endings. You can see them there. Now, notice that there's a certain kind of positioning there. The Meissner's corpuscles are going to be doing something different than the Pacini corpuscles. And the relationship between them, the kind of information they convey, has something to do with how they're positioned there in the skin. Pacinian corpuscles are going to be much more sensitive to pressure, deep pressure, than the Meissner's corpuscles. The Meissner's corpuscles are going to be responding a lot because they're right there on the surface. As soon as the skin is touched very lightly, they'll begin to fire. So they're going to be more sensitive. They're going to be tracking the spatial position of objects on them. They're going to be much more sensitive to the physical force that's applied to the skin. Now, the nerve endings are a very primitive sort of system that have a lot to do with pain reception, but they also respond to touch. Okay, here are the major receptors that are in the skin. You have the Merkel receptors, the Meissner's corpuscles, the Ruffini cylinders, and the Pacinian corpuscles. Now, the Merkel receptors, they sense pressure. So they're going to be, if you just touch lightly on your skin, they won't be stimulated. If you press down on your skin, then they're stimulated, indicating that there's considerable physical force being applied to the skin. The Meissners remember, they're the ones up near the epidermis, and they detect what's referred to here as flutter. But if you move your hand across your skin, the Meissner's corpuscles are responding and then being inhibited, responding, being inhibited. So you can actually map, even if you have your eyes closed, where your finger is moving across your skin. But they're very sensitive. Ruffini endings and Ruffini cylinders, they respond to stretching. And they're very important in detecting the positioning of your muscles. And I think sometimes you get cramps and things like that. It's a neurological response of these Ruffini cylinders and not necessarily just a response of fatigued muscle. But the Ruffini cylinders, when the structure there stretches, so when you stretch your muscle, when you contract and when you relax your muscle, you're going to be stretching these cylinders. They then respond, and your brain gets information that muscle is being moved. Finally, you have the Pacinian corpuscles here, which are down in the dermis, and they sense vibration. So, vibrating sense of pressure being applied to the skin is something they pick up and convey to the brain. Now, neurologists use all of these to diagnose neurological lesions, especially peripheral nerve lesions of the sensory pathways when you have disease of just those, because they go through and you may have seen on the doctor shows where a neurologist goes through with a needle and pricks the skin to find out how people are responding. They also use tuning forks, which they touch to the joints and the skin to find out if the person has vibration sense, if the Pacinian corpuscles, that system is working. Now, each of these receptors respond differently to the stimulation that makes them work. And this enhances their ability to localize a sensation largely. Now, think about these receptors and how they work, how you detect something as like a small flutter, a small sensation across your skin versus a pressure sensation. Well, if you look at the responding at the top there, that's referred to as slow adapting. So when you turn the stimulation on, they stay on. They don't adapt to it. So they don't stop responding until you turn the stimulation off. Now that's associated with the Merkels and the Ruffinis. Now think about the Merkel. You're pressing down on a location. Now it's important to know the location, but the location largely doesn't change if you think about how pressure is usually applied. You're more concerned with the duration of that physical force than you are with its location, even though location is still important. So you want the neuron to keep responding as long as that pressure is there. Ruffini is the same way. When a muscle is contracting or when it's relaxing, and the Ruffini ending is stretching, you want to know the duration of the stretch more than you want to know exactly where it is, even though location is still important. So these receptors are slow adapting. They're on for a period of time associated with the stimulus duration. Now the rapid adapting ones, they go off quickly. So the Meissners, like when you touch your skin, if you move your finger across your skin, you want the receptors to be going off as well as going on. You want them to go on and off, on and off, on and off, because there it's more important to know the location of the stimulus. So the Meissners and the Pacinian corpuscles, they respond in a rapid adapting manner. So they go on briefly, then they go off. Now notice that when they go off, they also respond. So you've got this stimulation here, this sort of stimulation path of on and off responding, indicating a direction or a path that the stimulation is taken across the skin by all the different receptors that are going on and off, on and off, on and off, as you pass the stimulus across the skin. The receptors also differ in their receptive fields, and what this refers to is the area of the skin that they respond to. And you can imagine that receptors that are detecting these different kinds of stimuli would be responsive to different areas of skin. So let's look at the different receptors and how they respond. Okay, the first one, the small responding fields, the receptive field size are small. They're the ones that detect pressure and flutter. So if you look at the area that they respond to, it's relatively small. So the distance across the skin, especially for a Meissner's corpuscle, is going to be very small because you want it to go off. You don't want it to be responding across a large area of skin, otherwise you won't be able to localize the stimulus very well. The Merkels also detect pressure. You want that to be a relatively small area of skin that they respond to, because you don't want them responding to a large area in which the stimulus may not be present. Now, stretching, though, is a large area. They're actually in the muscle tissue and things like that, so they're responding to a large receptive field. So a large area of muscle that's moving, or skin that's moving, they detect that over a large area. And that's also consistent generally with what's happening. You don't usually have an area of your skin a small area of it stretch. It's usually a large, broad area because you're moving around. That's usually what causes the stretching. So as you're ambulating around, large expanses of skin and muscle tissue is moving, and these respond to that. Finally, vibration senses are also large responders. So when that vibration sense occurs, it's hard to localize exactly where it's happening because the receptor is responding to such a broad area of the skin. Here's another depiction of the receptive fields associated with different receptors. What you do is you take an electrode and you monitor a neuron's firing, a sensory neuron's firing. You see that electrode up there with the firing rate up there in a little box. And then you take a stimulus probe and you stimulate different receptors to see if that neuron responds. And what they discovered was that in here you see very clearly the Meissner's corpuscles have these very, very small receptive fields, which you see there in blue. The Pacinians have a much larger receptive area. Now the Meissner's corpuscles are going to be trying to detect the location of a stimulus in a very sensitive way. And generally when you have small receptive fields in adaptive sensory systems, the system is designed to detect location. The Pacinian corpuscles, they measure something different, and they're not so that it's not so important that you measure location of the stimulus as you measure the duration of the stimulus and its intensity. And so they don't have to have such small receptive fields. Now you have to keep in mind also that these systems work together so that when you actually feel a stimulus, especially if it has some pressure to it, the pressure receptors are detecting that, the strength of the stimulus, and the Meissner's corpuscles and the others are detecting location of the stimulus. Here's an example of how they might all work together. So imagine you're reaching to pick up a cup, and you wrap your hand around it. Well, if you think about it, you're going to be using a variety of receptors to detect where the cup is, how much strength you might need to pick it up, what kind of pressure you have to apply to it in order to make it rise, and what its texture is. What does it feel like when you touch it? Well, as you slowly rub your fingers across the texture, you stimulate the Merkel receptors and the Meissner's receptors. And so they're detecting the texture that fluted texture of the object. Small details associated with the texture are detected by the Merkel receptors. And finally, when you stretch your hand around the cup so that you get the right distance in order to encapsulate the cup there, your Ruffini endings are stretching with your muscles. Now your brain is getting all this information about that object, and presumably also including vision. You just reach over and you pick up a cup. You don't think about all these receptors and all this work your nervous system is doing to make that happen easily and smoothly. But think about other organisms that don't have such good sensory systems. How difficult it is for them to do something simple like pick up a cup. They just don't have the sensory capacity to really detect small differences in texture and things like that. Certainly humans, when we became tool users and we became used our eye-hand coordination and no longer walked on four legs, it gave our hands an incredible sensory capacity so that we can do things like thread a needle, or actually sew something. Imagine if you had virtually any other animal try to sew something, even another primate. They'd have great difficulty with small objects like that and small degrees of coordination. And a lot of that has to do with the fact that their sensory systems are not as good as ours. Now you have neurons in your skin that have been especially adapted to be sensitive to temperature, to be very sensitive to respond to it. Their firing rates change when temperature changes. Now all neurons, your entire nervous system will respond to temperature, but these fibers have been especially adaptive in your skin to be very sensitive to changes in temperature. Now, they're the same types of neurons that convey pain information, and they actually go to the same places. And that's probably why when something gets too cold or something gets too hot, you feel it as pain. What probably happened over the course of evolution is that pain fibers, or the same fibers that were mediating pain, became adapted to mediating temperature very sensitively. And since that was so adapted to the environment, obviously, they became the temperature sensing fibers. Okay, we can see here they're very slow adapting type fibers. You have a great sensitivity to temperature in your skin, but these are relatively primitive neurons that are responding to this, and they have a long adapting pattern. The receptive fields can be quite small, but they're not as small as the touch sensations are. At any rate, they enable you to receive information for your brain to receive information about hot and cold, for you to avoid things that are, environments that are too cold for you or too hot. You have other systems in your brain that respond to what we refer to as homeostatic conditions of the internal state of your body. You have neurons in your hypothalamus that detect your body temperature and respond if it gets too low or too high. But these are not used apparently for you to sense the ambient temperature. That's all done through your skin. Here's a typical pathway of a sensory neuron. These neurons are very large, and they convey information very fast. Most of them are the most advanced neurons that you have in your body. You may not be aware that your neurons also evolved over time, and you have different sets of them some of them are more primitive than others. For example, the pain neurons are the most primitive in your body. They convey information relatively slow compared to these large alpha neurons that you have here for conveying touch. What happens is when you touch your finger, that neuron has its dendrite out there in your skin, and the impulse travels to your spinal cord. It travels to the dorsal roots where the cell bodies are for these neurons. Now you'll see a movie in which the dorsal root of the spinal cord has been selectively damaged, and these are people that have lost their proprioception and also their cutaneous senses, because that particular part of the spinal cord was damaged and other areas were not. But at any rate, it comes in the dorsal root. Its synapses there in the dorsal column of the spinal cord. The next neuron then conveys information to the thalamus. Then from the thalamus, it goes to the cortex. This graphic shows the sensitivity and receptive fields of different parts of your body. You can imagine that you have less sensitivity in your back and your calf muscles and so on than you do in your hands, fingers, your face. And this is reflecting that. This uses a method called two-point discrimination, in which you touch 2 points to the skin with a little device, and when the person is able to perceive that there are 2 points and not one, then you have the distance associated with that part of the receptive fields of that part of the skin. So you go along, you press 2 points, you start out very close together, then you widen them out to where the person says they feel 2 points, and then the sensitivity of that part of the skin. And you can see where it's logical that you don't usually have too many things that touch your back that you have to very sensitively track. Whereas when you're using your hands and your face, you need to have very great sensitivity, especially in your hands and your fingers, in order to pick up objects, to move them around, to manipulate objects. You need to be able to feel them in a very sensitive way. And so you have lots of neurons in those parts of your body that convey sensory information up to your brain. Okay, the somatosensory information is conveyed from the thalamus up to the cortex and is laid out just like you see it here. So the neurons that are stuck in the skin of your foot come up, go to the thalamus, and then come to the cortical area you see there associated with the foot. The neurons from your fingers come into the area you see associated with your hand, your face, and so on. And this is referred to as the somatosensory cortex, or the somatosensory strip. It's the cortical area that takes the first neurons that come in. Now, all around these areas in the parietal lobe are systems that respond to this information, the systems that correlate it with vision and hearing, and formulate a three-dimensional map of your body in space. So as you move your hands and your arms, your face, and all these things, all these neurons are responding in a coordinated way to orient your face and your hands toward objects in the environment, toward whatever you want to do. And they're integrated very, very intimately with motor systems. So the muscles that move your hands and your arms and your face and so on are also going to be coordinated with the sensory information. And you take this completely for granted. You don't think about, how difficult it is to do something simple like walking or something simple like shuffling cards. You don't realize how many millions and millions of neurons are involved in that so that you can do that in a very coordinated, seamless fashion. The movie I'll show you about the guy who lost his proprioception will really give you a clue as to how much you take this for granted. Also, people with spinal cord injuries, they realize that they've lost information from whatever part of the body that they have the injury downward to, and they realize the kind of information they were using to keep their body oriented in space that's gone now. People with amputations have very strange syndromes associated with the loss of sensory information, which I'll get to in a second. But the important thing to remember is you have a layout here on your cortex of the sensory systems. They correspond to the receptive fields and the number of neurons that are in each of those systems. So you see the face in the hands of humans is very large. The face in the hands of raccoons or a rat is not that large. They don't have the same sensitivity that we do, especially in our hands and in our mouths and faces. Now you got to think about, why do we have so much sensitivity in our mouths, for example? Well, that's in order to coordinate all the movements associated with speech. In order to express ourselves in language fluently, we have to coordinate a lot of muscles in our face and our mouths and our tongue and things like that are far beyond what you need for something like eating. And in order to do that, you need lots of neurons, all coordinated to produce the motions associated with speech, with language. So the layout corresponds to the number of neurons that are in that position and the tightness, the smallness of the receptive fields. Now we come to the phenomenon of phantom limbs. Now what happens when you have an amputation, like you see this guy here, when you have an amputation, you just don't lose the functionality of your arm or your hand. You also your brain loses the sensory input it had from the cutaneous sensory systems that were in that part of the body. Well, you have to ask yourself, what does your brain do now it's missing all that? Well, it does some remarkable things. It tries to reorganize things, I think largely because your brain has never not had an arm there. And so it tries to reorganize information so that the hand is maintained. And what your brain actually creates is a kind of hallucination of an actual limb being there. And so many people with phantom limbs describe this, that it's obvious that it's a common result of many different people and how their brains are accommodating to the loss of the limb. Now, for some people, the phantom limb phenomenon comes and goes. Some people it's never created. Some people, they have it for a long time, and then it goes away. It's a representation of how the brain is trying to accommodate to the loss of sensory information. And since your body schema is still there, see, your brain has not been damaged in terms of its body schema. the scheme of how your limbs are laid out, how you orient yourself in space, all that is still in your brain. But for some reason, your brain doesn't understand that there's been a loss of one component of that system. And rather than figure out a way to deal with the loss and sort of accept it, your brain actually makes a limb there. And the phantom limb becomes this artificial construct of your brain that keeps a limb there because it's consistent with the body schema that's always been there. Now, because you don't have the sensory information, all kinds of strange things happen. And I'll just let the movie speak for itself. Basically what happens is you have the reorganization of the hand and the face because now a hand is missing. And remember, the hand and the face were next to each other. And there's some kind of reciprocal interaction between the hand and the face. That when the hand now is gone, the face then takes it probably isn't inhibiting the hand anymore. The hand isn't producing any stimulation. And so your brain's composite, what your brain formulates out of that composite pattern of stimulation, is a very remarkable thing. And I'll just let the movie speak for itself. Go to the website, see the movie on Ramachandran and phantom limbs. This is another aspect of the phantom limb phenomenon. It's also in the movie, so I'm not going to elaborate it here. But basically, it illustrates the role of vision in the creation of the phantom limb. If you have visual, now remember, vision will trump all other sensory systems. So if a primate sees visual information consistent with something, it will accommodate to that visual information, and it may not to others. Now here you have somebody with an amputation. They put their left hand in a device that's got a mirror in it. And when they look into the mirror, they see what appears to be their right hand moving. Well, most of the time the phantom limb of an amputee is completely stiff like a stone. It never moves. Well, when the person does this and they see what appears to be a right hand moving, their brain accommodates to that using vision, and they then have the perception that their phantom limb, the limb that's not really there, the one that's been created by their brain, that limb is also moving. Pain is a unique aspect of cutaneous stimulation. I think we all know what pain is. It's hard to avoid when it occurs. It has a very compelling influence on our behavior and our motivation and our emotions. However, it is just information that's coming in from our skin. Now, pain is a very ancient system in terms of evolution. It's something, obviously, that even very, very low-level organisms have. It's obviously very adaptive. You want to feel pain when you're in a situation that you're being, injured or damaged. Unfortunately, the system is so crude that it will often respond when there actually isn't some situation that produces, damage and so on. And also, it can't be turned off very easily once you understand, why you're damaged. You don't need to continue to feel pain. That's always been very irritating. I mean, whenever you fall down, you hurt yourself, and you know why you're hurt, you're trying to get yourself fixed up, and you still feel the pain. It's like there's no way to turn it off when it needs to be turned off. Fortunately, these days, there has been advances in medicine to the point where analgesics are really good, and, if you ever get to the point where you really want your pain turned off, there are ways to completely eliminate it. But they're not over-the-counter prescriptions. It's something that you can use in just minor situations, like when you hit your thumb with a hammer. Well, pain is conveyed by a primitive system of neurons. It starts out with free nerve endings in your skin, and then these nerves travel in the same basic system as a sensory system generally, but then they break apart in the spinal cord and travel a completely different pathway up into your brain compared to touch sensations. Now, anesthesiologists use this to tailor anesthesia for pain without you losing your sensory system. If you're familiar with spinal blocks and epidural blocks that women get when they're delivering babies, what that system does is cut out the pain sensations but leaves the touch sensations. Or may not. Sometimes they cut out both touch and pain. But they can tailor the medication so it selectively takes out the pain, because you still want your touch sensations to be there as the brain monitors contractions and things like that. But at any rate, the system is primitive. It can be stopped. It's usually the membranes of that system are differently structured. You can stop it with a different chemical and stop pain from being conveyed, but touch still will. There's even a theory that The touch sensations inhibit pain, so that's one reason that we tend to touch areas of our body that are injured, or you see dogs licking their wounds, because that licking sensation being touch will override the pain somewhat. Now, I've never found this to be completely effective. Maybe it's a little effective, but maybe it's more effective in dogs than it is with humans. But theoretically, the fibers associated with touch, they have to get to the brain. Your pain fibers, being much more primitive and much slower, can be inhibited by the touch pathways. And so touching an area that's been injured might actually reduce some of the pain. Okay, well, here you see a graphic in which you see a stimulus down below of temperature being increased, and you see the human psychophysical response to that. So the humans are saying, yes, it's getting colder and colder and more painful, and they're showing you a graph of the degree to which the pain is changing. And since this particular study didn't actually observe the neurons, didn't monitor the neurons, however, they did monitor the neurons in monkeys, and they discovered that the nociceptors, the pain receptors of the monkeys, were changing their firing rate associated with the stimulus, and it roughly matches the human psychophysical response. So probably what's happening is the firing rates of nociceptors in your body are increasing when you feel pain, and they increase in this curvilinear relationship to the stimulus. Now, I notice that it's a curvilinear relationship, and that corresponds, I think, to our perception of pain. There's a certain point at which pain just becomes god-awful pain. We can't make distinctions between levels of high pain. We can kind of make distinctions at lower levels, but as soon as it gets to a certain point, it's just incredibly painful. And we can't sit there pondering, well, this is, more or less painful than another stimulus. Now we've kind of reached a threshold and overwhelmed the system. Okay, here we have a layout of the two systems, the pain system and the touch system. And they're indicated by the two different colors there, blue and green. Now, if you look at where the free nerve endings are, on the right side there in the skin, see there's a little section of the skin there. See how there are free nerve endings coming up into the system? Notice that those free nerve endings, which are depicted in green, are going to a different part of the spinal cord than the blue ones are. The blue are indicated are the proprioceptive fibers and touch fibers. They're using the blue route there, and the pain is using the green. Now notice that they're separated in the spinal cord, but they come together up in the thalamus and the cortex. So your pain receptors eventually reach the same cortical areas as your touch receptors, but they're using a system that was designed a long time ago to convey pain selectively as opposed to touch. Because touch fibers, especially in primates and higher mammals, have evolved quite a bit. And so a whole separate system eventually evolved to handle that kind of sensory information. Subjective experience of pain is processed by the cortex. So your feeling of pain is something that the cortex constructs given stimulation from the pain system. And you have different parts of your brain that respond to pain fibers and pain stimulation. Obviously, pain is something that's very emotionally provocative. So when you feel in pain, it produces a mood state of high anxiety, of concern, maybe of depression some, but certainly of anxiety and panic, that sort of fear response. And that's what it's supposed to do, because obviously if something is hurting you to the point of producing pain, you have to respond to it. You have to be motivated to change your behavior to accommodate to the pain. Well, if you take different parts of the limbic system, which are shown here, this is a graphic showing the frontal lobes. The green area there is the part of the frontal lobes that deals with the limbic system. It's part of the limbic system. The limbic system mediates emotion. Now, when the limbic system is stimulated, you have various kinds of emotions, and as you know, emotions are not very well modulated. They're not like you've got a clear distinction between, anxiety and fear, or even depression and anxiety. All these things get kind of blended. At any rate, though, when you lesion different parts of this system, you can eliminate pain. You can eliminate the emotional component of pain. The person may still have a sensation of pain, but clearly the emotional anxiety part, the fear part, can be greatly reduced. And there is a neurological procedure, a neurosurgery procedure for lesioning the cingulum to reduce the emotional components of pain. Now, this is done in very extreme circumstances for people that have had chronic pain for many years. You don't get brain surgery for this just from incidental pain. It's got to be a pain condition that's uncontrolled by medication and so on. And doing a cingulotomy does reduce the emotional components of pain and can be very effective in making people feel better about their pain, even if they're still experiencing a sensation. And people that have frontal lobe lesions, naturally occurring, well, they usually occur in trauma. I don't know if that'll, but naturally occurring in the sense they weren't produced by a neurosurgeon. They have the naturally occurring lesions often have a syndrome where they do not experience the emotional aspects of pain. And I remember very distinctly when I was covering trauma center that patients with frontal lobe lesions would go through some of the most horrendous procedures, to fix their fractures and their orthopedic injuries and stuff that would make you just lift right off the bed in pain. They'd be laying there and these horrible things would be happening to them, and they would say something like, ouch. They have this sort of very bland, indifferent sort of emotional reaction to the pain. They were still obviously feeling something, but the emotional component was completely lost, and they were more or less indifferent to it. Now, you could see if you were indifferent to pain, how you would, you wouldn't change your behavior to fix yourself. And somebody that doesn't have an emotional response to pain is not as well adapted as somebody who does. Now, one of the big questions about pain control has always been, well, suppose somebody's in pain and you distract them with stimulation that's pleasant, or you distract them somehow. Does their pain sensation goes down? And so a number of studies have been done to examine this, and there is an effect of this. If you have somebody who's, usually what happens is they administer, well, here you see a paradigm in which the subject is put in an experiment where they have to put their hand into very cold water. And I've heard this study described by, this paradigm's been used in a variety of ways to study pain perception and as treatment by medication. But here you've got somebody who puts their hand in very, very cold water. Okay, well, they'll leave it in there for a while, but then at a certain point, this cold water becomes very, very painful. And so you can time the duration of the pain, the intensity of the pain, and so on by how long the person keeps their hand in this very, very cold bucket of water. And it's not a pain sensation that hurts them or anything like that. It's not a condition that hurts them or damages the person. It's very hard if you think about it. Well, how do you study pain without inducing pain? If you induce pain, you have to hurt somebody. Well, this is a paradigm that doesn't hurt them, that also allows people to study pain in a very systematic way. Well, when they were looking at pictures, while they had the hand in the water, if the pictures had a positive emotional tone, they kept their hand in the water longer. They were more distracted by them. It was much more of a positive emotion that was associated with the picture, presumably counteracting the negative emotions associated with the pain. But if they saw negative pictures or neutral ones, they kept their hands in the water much shorter times. So there probably is a factor, especially at an emotional level, for distracting people from their pain, especially distracting them from the emotional tone of the pain, which is obviously always negative. If they can get distracted by something that's more positive, their pain sensation will probably diminish. And here you have a graphic depicting the spinal gate control theory of pain. And the gate control theory is just a mechanism to explain how touch fibers, these more advanced long fibers, influence the perception of pain. The basic idea rests on the assumption that the L fibers and the S fibers are in a kind of conflict, that the L fibers, because they're conveying touch information, that has higher priority in the central nervous system than pain perception, which probably is valid. If you're going to have a choice, that would be the one you would want, because it's more important to know where you've been injured probably than simply to feel the fact that you've been injured. Okay, well, what happens is the S fibers, the short fibers conveying pain, if they're active, then there's no inhibition of the system, and they convey pain information to the T fibers, and you feel pain. If, however, there's touch also present, so the L fibers are there being stimulated, they will inhibit the S fibers. So they close a gate. They inhibit those fibers from conveying information to the T fibers. The touch fibers then have ascendancy, and they convey information to the central nervous system and inhibit the pain fibers. So this is a system that's theoretically supposed to exist. There's evidence for it from a variety of different studies. There probably is something like this. Generally the nervous system works this way, where you have this dynamic balance between systems, and you have priorities, and you have a systems designed so that certain information that's more important gets in, and lesser information that's not so important doesn't make it. However, my personal experience with feeling pain is I don't really have a sense this works that effectively. No matter how much I, touch the area that's been injured, I still feel pain. It still gets through somehow. I think what this system does is it tends to dampen the sensation of pain and probably doesn't eliminate it altogether. Okay, we've known for hundreds of years that things like morphine and heroin have a strong influence on pain perception. And what's theorized that these substances like morphine and heroin are working like endogenous transmitters, endorphins, that moderate and control pain at the brainstem and the cortical level. So the pain fibers come up into the brain, but the perception that the brain constructs of pain is strongly influenced by the action of endorphins. And all kinds of ideas have been proposed for endorphins. Once they were first discovered, everything from running, there's an endorphin high that you're supposed to get from exercise. All these things are quite theoretical. They do also deviate from the primary role they probably play in pain perception. But at any rate, and many of their sites are not known. So it's obviously they work in the central nervous system, but all the areas of the central nervous system, especially in the limbic system that's mediating emotions, are less known. They also have other influences on the central nervous system besides reducing pain. They can make you actually feel euphoric. They make you feel different, opposite from in pain. They can also suppress your respiration and your whole central nervous system. Obviously, people can die from overdoses because of the suppression of the limbic system, the autonomic systems that control things like breathing. But the point is that there are receptor sites for pain perception in the brain, in the brainstem, that are strongly influenced by the presence or absence of endorphins. And morphine and heroin, the opiates, are artificial endorphins, essentially. They work in a similar way as your endogenous ones. It's just they produce, obviously, an artificial effect. Now, when they're used as analgesics in the hospital, they can play a very important role in controlling pain, and that can be crucial in treating people. Because once you get them past the pain window of recovery, your body repairs itself and you don't feel pain after a while. Without those analgesics, I have no idea what physicians must have done in the past. When people would be in horrible pain, being conscious and alert and just feeling the pain, continuously, it must have been just a horrendous to have a serious illness back before there was the regular use of morphine and other analgesics.